Welcome to Healthcare Musings, a podcast dedicated to the discussion of critical care and healthcare in general. Here's your host, Dr. Hesham Hasabala.
Everybody, Hesham Hasabala here in Healthcare Musings, and I am so delighted to have on the podcast today Dr. Greg Johnson. He is a colleague, he is a friend, he is one of the great minds in medicine, which is why I had to have him on the podcast. He is currently the Chief Medical Officer of Unity Point Health, and he was formerly the Chief Medical the CEO before the Chief Medical Officer, and then the CEO of Hospital Medicine, and then he became the Chief Diversity Officer for Sound Physicians. So he was the CEO of Hospital Medicine for Sound Physicians. Then it was the Chief Diversity Officer, and now he is at Unity Point Health. And I am super stoked and excited to have Dr. Greg Johnson on the podcast. Good morning. Welcome, sir.
Good morning, Hesham. Great to be here. Thanks for inviting me.
Absolutely. Absolutely. So I know that you're very big into the health equity space, and you had a podcast when you were crossing the chasm. Are you still doing that, or?
It's on hold until I can get more settled. I've only been at Unity Point for about 3 months. A lot of getting my bearings, but it's absolutely coming back at the beginning of 2026. So thanks for the early advertising for it when it comes back.
Yeah. Oh, absolutely. I mean, it's a great podcast. Really great things. Great. He has great guests. Great, better than my guests. And although present company excluded, of course. And I was honored to be a guest on his show.
Yes, you were.
And it was just a fantastic show, fantastic conversation, and I look forward to this one. So, kind of where do you see it now? The healthcare today. Let's just kind of start there from your perspective, and then we can talk about kind of health equity.
Yeah, I think healthcare globally, right, it's just a volatile space. I think, we are collectively faced, not only from hospital and health systems, but also individual physicians in terms of a space where we need to deliver care. The pandemic highlighted that more than ever. But now we're in a time where costs are being evaluated in every way, shape, and form. Physician payments are being ratcheted down, hospital payments are being ratcheted down. There's consolidation that's occurring everywhere. And in the meantime, our population continues to grow and continue to get sicker through either chronic conditions of care. Diabetes continues to skyrocket. Lung conditions, you as an intensivist are seeing more and more patients entering our ICU spaces. And we still continue to have an older population that we have to care for. And so we're just in a volatile space in terms of trying to figure out how are we going to actually develop a system of care that helps us to care for our patient populations and ultimately get better outcomes, despite the fact that we have twice as much stuff as everybody else in the world. We're still lagging in terms of clinical outcomes. Then, and you brought up the health equity space, it's figuring out well, what does health equity mean? Why are we focusing on it? And what's the point when we need to take care of everybody? Well, we do need to take care of everybody, and I've shamelessly stolen this, and I wish I could remember the individual, but there is no quality without health equity. If we're not focusing on making sure that all of our patients have the opportunity to get similar outcomes, then we cannot say that we are doing what we set out to do in terms of saying first do no harm and identify our opportunities to help our communities. So volatile space, lots of opportunity for us to do better. It's an interesting time, but I am optimistic that it's a great time to be in medicine because it's an opportunity to really shape the future.
Yeah, that is interesting. It sounded to me like it's not sustainable. I mean, healthcare needs resources, right? And everything's being squeezed. It seems to be not sustainable. What are your thoughts?
It's current state. I don't think it is. We don't. So we have a system that pays for us to do stuff, which in many instances has given us the system that we have, right? So we do a lot of procedures, we do a lot of things to people,
Mhm.
as opposed to really figuring out what we can do for people. And in
Mhm.
many instances, as you are acutely aware, sometimes doing less is doing the right thing, even
Mhm.
though that's not necessarily what we have really trained our communities and even each other as physicians to do. And so, really being thoughtful about the care that we're providing, really being thoughtful about how we pay for all of that. And I'm I don't shy away from discussing the payment models because they are fundamental to how we alter our overall paradigm of healthcare to allow for physicians to be able to sustain practices. These are, that we physicians don't work for free,
Mhm.
nor should they be ashamed of saying that they don't work for free. They've invested heavily in themselves in order to be able to give back to their communities and to individual patients. Hospitals and health systems have infrastructure that have to be paid for in order for us to care for patients. And so, fundamentally, rethinking how we come up with a payment paradigm, how we address physician well-being within that paradigm, and ultimately deliver the outcomes that our patients and our communities expect, does require, some people would call it radical. I simply think it requires rethinking because we are in a different stage than we were in the 1960s. um, and we
Mhm.
have to do things differently.
Do you think, though, it's just not American? Like I'm saying, there are, you know what I'm saying? Like there's, my daughter's a first year medical student, and thank God, and
Congratulations.
thank you, that just the generation is just different, right? And our culture is different. We're not used to being told no. And it seems to me that you have to say no in healthcare, or am I missing
No,
something?
I don't. So I think you're right. There's many in the initial reaction is to look at it and say, oh well, this is rationing care and that's un-American. We're gonna get away from doing that. And I've certainly invited people to think about this differently, which is we have become, because of the cost pressures, because therefore the time pressures that come with it. Time is money. We have gotten away from the opportunity to engage our patients in meaningful discussions. So my father passed about 2.5 years ago,
No, I'm sorry.
and I know he was 15 years after a heart transplant, which means that he was blessed to have more than his fair share of time after that. But I recognize that what would have happened with him had he not had me as an advocate, had he not been trained as a physician, would have been such a different outcome than had others done it. And I invite people to think about it, which was, everybody should know that their life is finite, right? You're born, you're going to live, we are all going to die
Mhm.
at some point in time. And inviting our patients to have the conversation on how do you want to engage the healthcare system is absolutely critical, because I know for my father it was very clear, and this is an evolving conversation, right? It is, what do you want, right? Do you want to spend all of your time in the hospital? Some people may want that, right? My grandfather, so my father had one thing. My grandfather was like, if they come up with a drug on Tuesday and I need it on Wednesday, give it to me, right? Okay, understand that. People should have access to that. But so many other patients are like, no, I want to be around my family. I want to be at home. I want to, and engaging in those conversations to understand, well, okay, so I'm not saying no to you. I'm giving you the care, but that does mean we're not going to be doing certain things. And engaging in our patients in that kind of dialogue suddenly makes us much more compassionate. It does allow us to care for our scarce resources in a way that is more meaningful, and candidly, I think brings more meaning to what we do as a healthcare system and as physicians within that healthcare system. And so, and to the point that I was making, we have to be fairly compensated for having those hard conversations, because you and I both know those aren't easy conversations to have
Yo,
when you're perfectly healthy.
100%. And they're time
Nobody wants to
consuming.
discuss their mortality when they're healthy. But I know that if we engage with people, and I don't think this is a Pollyanna perspective, but understanding that we can save money, do the right thing, and allocate resources for the individuals that need it and want it more, just makes more sense. But instead, it is churn, 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 do as much as you can, do as much, and then say, well, now that we've done everything, and oh well, the outcome is going to be the same. That just it just doesn't feel right to me.
I totally agree. In fact, we as intensivists do it all the time.
Right.
Like I did it yesterday, literally yesterday. I was on
Right.
shift. I just finished 7 days in the ICU. Literally, I had this conversation yesterday about someone who clearly is going to need long-term mechanical ventilation, clearly, and he did not want that.
Right.
And so I told the family, I said, then I can't do it. We just can't do it. And so am I part of that solution, for lack of a better, I mean, is to not say no, but to provide care? Because I don't know that we ask our patients, what are your goals of care, right?
Yeah. What do you want? What do you want out of this? You'll forgive me for giving another story, but it's still one of the
No,
most
I love the
powerful,
stories. Go,
is the
go.
most powerful moments with me at the bedside. And I think you'll appreciate this, right? This was a gentleman that came into the hospital. It was acute renal failure, had lots of signs and systems that were lots of diagnostic criteria that really were leading towards a myeloma diagnosis. And comes in, and I remember he had 11 children. And as a hospitalist, that used to terrify me, because it was usually the family was disconnected and there was going to be a fight over this. And I remember, he's on dialysis, put in his catheter for dialysis for short term, finally get his diagnosis, sit down with him and the family. And I'm, dreading having the conversations, confirm myeloma, not a lot. He's pretty far down the line, not a lot of, he does have treatment options, but he's gonna die from this.
Yeah.
And I vividly remember all 11 of his kids in the room with his wife and him. And he looks at me and he says, "Doc, if I stop all of this together, what happens?" I said, "Well, you'll probably die of renal failure. It'll be quiet. You'll likely just go to sleep and you won't wake up." And he was like, and he was a minister. And he turned to me and he goes, "Well, take the catheter out. They know where I'm going. I know where I'm going. I'm done here." And I remember sitting back for a second. I was like, what just happened? His kids started packing his bags instantly. And I remember getting a very nice note saying, "Thank you for getting us into hospice care. Thank you for everything you did with us. We got to do exactly what we wanted to do as a family." And I remember sitting there, and it was very early in my career. And I remember thinking to myself, I owe my patients this conversation, because I had determined what this conversation was going to be. And it was the polar opposite, and one of the most beautiful moments I ever experienced in healthcare. Because it was really the power, not only of faith, but of having the conversation in terms of that. And I was just like, I owe this of patients, and I wish that I had space to be able to create to do this. And it's not just an end of life care; it's in anything.
Absolutely. I think I say that as an intensivist, I win. I hate to use that word. I win when a patient conquers critical illness and we help them. That's why I became a doctor, right? It's fantastic, right?
Right.
Even though I don't remember, they remember me and they come back, and that's so awesome, right?
Yeah. Exactly.
In fact, this week I'm going to drop an episode about how patients and their families can help with burnout is by sending a thank you note.
Oh my gosh. Yeah.
I get
Yeah.
a thank you note. That sustains me for so long. And people should do that. Take the
It
time.
does. It does, because at the end of the day, like it is that connection. It's the reinforcement that you know that you did something right and well, and it's just reinforcing excellent behavior. So yeah, I
Absolutely.
agree.
And then if I can help mitigate someone's suffering, like that patient yesterday, if I can provide care within his red lines, within his values and preferences, and that means that they don't suffer all the way to death. Because before that conversation, I coded somebody and he didn't make it. And that's not a dignified death, right? But so you had both ways of the spectrum, right?
Yeah,
But if I can help mitigate their suffering, and I say minister to the family and help them, I win. I hate to
yeah.
use that phrase,
I understand where you're coming from.
you
Yeah,
know, and
completely.
so and I think, and I talked to Rob Bessler earlier, and on the podcast, and they're talking about it in the office, and I think they need to start. It's too late when I do it, right?
Yeah,
It's way too late when I do it,
it is.
and I'm forced to do it all the time,
Yeah. Yeah,
all the
it's
time.
we are as hospitalists of, and it's the worst time to do it, right? You
It
are at
is.
a crisis moment, and now you're forced to make a crisis decision, when you can readily inform, because again, I've had the flip side happen when people are just like, and I understand it of, oh my gosh, but and here are the parameters of, I want you to be able to, it's still, again, vivid memory of somebody going, okay, well, they need, they're going to be, how long are they going to be on the ventilator? Well, I don't know. Well, okay, well, can you give us a sense? Because we want to see progression, positive progression. And when
Mhm.
we need you to have the conversation with us, because if we take steps back, it will alter our thinking. And it's again, it's engaged dialogue, but it's creating the time, the space, and candidly, again, I don't run away from it. The incentive that if I like, there has to be the backing to create people to have the space, because otherwise you get what you pay for. And if it's paying for doing more stuff and putting more stuff on people, it's problematic.
Yeah, 100%. I agree with you.
Yeah.
My co-fellow is Dr. Omar Latif. He's now the system CEO of Rush University Health System, and they were talking about getting to the health equity space, like the the life expectancy in the Gold Coast of Chicago, I think, is like 15 years longer than the West Side, which is not even a 5-minute drive.
Yep.
And they're working on trying to remedy that problem. That's stark. That's so stark when you think about it. Um, what me as an intensivist, we open the doors to everybody, almost
Right.
everybody, right?
Hmm.
So it's like everyone's. You can use our, as long as we have the capacity, you can use our resources. But you look at what are concrete steps that we, as a system, clinicians, can start to eat away at health inequity. Because I agree. I like what you said, that there's no care without equity. Like, everybody has to have access to care, but that's sadly not the case.
Well, it is sadly the case. So I tell people, we were trained in medicine, which means we were trained in evidence. And I sat down and I was just like, it's a big problem. Where's the evidence? Well, go back and look at the Institute of Medicine, now the National Academy of Medicine's report, Unequal Treatment, was written 21 years ago. And it's a treatise, and it's a well written, well established, that not only confirms that health inequities have existed in this country for over 60 years, but more importantly, a step by step set of recommendations on what health systems and organizations can do to resolve that. Now, interestingly enough, in May of this year, the National Academy of Medicine released its follow up report called Ending Unequal Treatment. And what's a little sad, not a little, it's a lot sad, is the first portion of it is like, well, we put that out 20 years ago and basically nobody did anything that we asked in the report, or very few people did. And then the latter portion of it was really an outline on what needs to happen, and again, addressing funding from a federal perspective to address funding. I have said, I've looked at both reports on equal treatment and ending unequal treatment, sort of like um, it's the L isomer of the same drug, which is like, and I would go back to the generic drug, which is, let's go back to the 20-year-old report. And and it's really saying, what can we as a health institution, and this is certainly what we're doing at Unity Point, do in terms of evaluating what concrete steps can we take. There are essentially 17 specific objectives, and there's sub-objectives within there, but there are big and small things, right? On the clinical side, and we did this within Sound, and it's a huge opportunity for, I think, most systems, is redesigning multidisciplinary rounds to formally incorporate social determinants of health, and not just saying that we do it, but then what do you do with it, right? Because if you take those steps in identifying the social determinants of health, and then identify what you can do, because again, we as physicians are, and hospital and health systems aren't going to solve this, right? Job
Right.
insecurity is not something we can all fix, but we can say, oh, transportation's an issue. We tend to have access to addressing transportation. There are housing things, knowing what you have in the housing insecurity, knowing what resources you have in your respective community. And we, again, at Unity Point, have done a lot of work in identifying by market community resources that we can then provide prior to a patient's discharge from one of our facilities, so they get plugged in and get communities. Leveraging community health workers as a specific recommendation, knowing that you can take those individual steps, and I just named 3 recommendations that are off the top of my head,
Mhm.
but looking at those recommendations and really saying concretely, what can we do to be able to do this? Simply evaluating your own systems, and to the point of view as an intensivist, but it's getting as granular as possible of saying, and again, it was something done in Sound. It's something we're actively doing in Unity Point, of saying, well, where are existing disparities? Because while there are national ones, how are we contributing to the problem? So more importantly, we can identify the problem, something that we as doctors do all the time: identify the problem,
Yep.
diagnose, and then what do we do to treat it? And again, as a system leader, as a leader within an ICU, it's, well, I do diagnose and then I do treat problems. Treating problems, addressing the problem. Okay, well, I'm being a doctor. I'm taking data and then I'm applying my knowledge to figure out what we're going to do differently. And so to
Mhm.
me, I tell everybody, the evidence exists. Go read it. It's not a page turner, but go read it, and then sit down and figure out what can you do. Because even if you're taking a single step, that is helping to mitigate health inequities, and it gets into the pattern that we learned in medicine, and that's reinforced with our public health colleagues, which is, then how are we engaging our communities in terms of, I'm not doing something to you, but how do I gauge it so I do something for you? I mentioned the community health workers, but it's also the community, engage in the community in terms of research. Stanford did some excellent work in terms of looking at what you can do for community scientists, in terms of saying, hey, we can identify what's going on, but hey, I can come in as Dr. Johnson from Unity Point, and I can go out to rural Iowa and say, oh, yeah, well, I know your problem is going to be telemedicine, but if they turn around and tell me we don't have reasonable broadband access and people don't have access to computers, I haven't created. I've named a solution that is inapplicable for them. How
Inapplicable,
are we
right.
going to engage these these poor outcome, underserved communities, in terms of a way that it's meaningful for them, so that way they can help build trust with health systems, as opposed to where the healthcare system in many instances has treated historically disenfranchised communities pretty poorly. And
Mhm.
so I tend to just go back to the evidence and say unequal treatment is a wonderful place to start. It's a place to build. And then utilizing our clinical knowledge, partnerships with public health, and partnerships within the communities to be able to provide them not only visibility as to a negative outcome, but what we can do to ultimately fix it. Because there are tons of solutions out there, but until we are willing to engage in a different way as healthcare providers and healthcare systems, we're going to continue to see what we've seen historically, which are really poor outcomes in historically disenfranchised communities.
Mm. That's fantastic. And I'll link.
I lost you, Hesham. Hold on.
I was going to say, I will link both reports in the show notes. So people can do that. Should we address, so when you say social determinants of health, just so that I and the audience knows, what are you talking about? Oh, I lost your audio.
Am I back?
Oh yeah, now you're back.
Okay, yeah, I had
So when you
lost you.
say
Now you lost me. Yeah.
when you say social determinants of health, what do you mean?
So social determinants of health are well-researched areas of health that don't necessarily correlate with race or ethnicity, but are really components of healthcare. So if you components that aren't necessarily medical that are associated with healthcare outcomes. So I highlighted transportation or transportation insecurity as one area, right? And for non-clinical listeners, or maybe even some of our the clinical listeners, transportation insecurity is, right, you have an elderly patient, they don't drive, they don't have family, and so you tell them, go pick up your drugs at go I need you to go follow up with your primary care physician after discharge, and they're like, that sounds wonderful, I have no way to get there. Right.
Right.
Housing insecurity, I think, very straightforward. Food insecurity, which I think we tend, particularly in this country, to take for granted, but there are food deserts that exist in major metropolitan areas as well as rural America. And so really breaking those areas, and there are typically, at least in certainly in the inpatient space, there are probably 11 that are directly correlated with differentiated poor, meaning poor clinical outcomes for patients. Those are the types of things that we're discussing. And again, from the clinician's perspective, screening for those, and for those who don't know, CMS, or the Centers for Medicare and Medicaid Services, came out with not only recommendations and suggestions for the screening tools, but then actually additional payment that goes along for screening for those. So getting, trying to solve the entire problem, but really saying screen for them and then utilize what resources you have to be able to support them. Don't solve all of their problems, but at least ask, so that way we know what can potentially cause a patient to either fail care in the outpatient space or be readmitted to hospitals.
Should we be asking about that during my ICU rounds? Or maybe at a hospital?
So,
I mean, like,
so it's funny.
should I add that
When
to
you-
my, is it A, B, C, D, E, F, S?
So it's interesting. There are a number of screening tools, and it was very interesting that you brought it up, because Sergio Zanatti, one of your colleagues, brought this up with me when I was with Sound, and he was like, "My patients are typically on ventilators. I can't ask them anything." And I was like,
Mhm.
I understand where that comes from, but I will say that on the hospital medicine side, there is tremendous opportunity to ask for these. And again,
Yes.
when I think of redesigning multidisciplinary rounds, it's take the opportunity to screen for those. There's wonderful screening tools that are actually tech accessible, 10
Okay.
questions, highly reliable. I can't remember a couple sources that I'd pull off the top of my head. I want to say Northwell Health had a really good one, and then and then I believe that I won't overstate that. I want to say HRQ had come up with one, but there are several that you can actually access online that are quick screening tools that you can put in the hands of either nurses or physicians to be able to get to the questions. UnityPoint absolutely has a screening tool that's built into Epic for our patients.
I was going to say, yeah, the Epic, they have those little hands that keep, that I see on
Exactly.
the summary, and I just like, okay.
Yeah,
What's the potassium today?
and so we have all of that to be able to do the screening, and then there is downstream work that has to be done. Again, we have partnerships through some national relationships that we have to help identify community resources by market. So again, it's not incumbent upon the physician or nurse practitioner to solve these problems, but now we've done the screening and now we can say, oh, hey, we need you to plug in with such and such in your community, and we've helped to facilitate that.
Mhm.
Those are the things that actually have material impact on length of stay, that have material impact on readmissions, have material impact on mortality. And if we are doing that on a consistent basis, I absolutely believe that, I mean, it really should be done in outpatient space, as you mentioned. But again, our primary care colleagues are pressed for time. So I think wherever we can do it, we should be doing it because it is getting us more robust information about our patients and better ways to be able to support them in beyond what we do clinically.
Yeah, no, that's great. And in fact, I'm pretty sure I'm going to be taking over Quality and Patient Safety Committee at my hospital, and perhaps we can start, especially when it comes to readmissions, for those big things. If you want to get CMS 5-star and you want to
Yep.
improve readmissions, maybe really trying to focus. If it's, and I'm not saying it's not being done. I still have to learn, but maybe we really start to implement social determinants of health in that to try to screen for that or try to fix those things so that, and then I think you'll see downstream effects.
Yeah.
Do you still do clinical work, or are you all?
It's not scalable in my current role. It really wasn't scalable in my prior role, and it's not here. And it's a great question from a
Do you
healthcare
miss it?
physician. I do. I miss the connection with patients, and the connection with colleagues. And there was an article that came out in JAMA a couple weeks ago, specifically about administrative harm, and it actually resonated pretty heavily with me because it's you and I uh, see this certainly as leaders, but there are arguments that happen in the physician lounge and every place else of, oh, those administrators, they don't know what they're doing, they don't know what's happening here on the ground. And when I moved away from the bedside, my first thought was, well, how do I rectify that? Because God forbid I do end up in an ivory tower, and get completely disconnected from the work. And for me, it was in Sound, and it is here at Unity Point now. Okay, well, if I can't do this work because I've got other things to do, then how do I spend as much time in the facilities, in our clinics, with our physicians, so that way, if I'm not directly connected to the work, I'm connected directly to the people who are doing the work because they're, as the administrative harm paper reads, right? That disconnection, that lack of really understanding that a macro decision made at a system level has direct bedside implications. And it's never going to be perfect, but how do I help to make sure that those dots are connected and I can communicate with them effectively on why the decision was made, and they can provide feedback in terms of what changes it's made, positive, better, negative, otherwise. So that way they just know that there's open dialogue and that the work that's being done at the bedside is always respected. Because I think that's the real issue about administrative harm, is it's a lack of respect for how difficult the work is at the bedside. And if I personally can ensure every physician, every nurse practitioner, any member of the care team knows I respect their work that you're doing, and everything that we're trying to do at the system level is in support of you as a team member because you are committed to improving care for our patients. And so it's a it's my own soapbox moment in terms of saying all leadership has to stay connected, figure out how you're going to do it, because at the end of the day, if you can't do the work, get as close to it as you can, so that way you're not making bad decisions.
That's great. That's great advice. I think I'm still able to do that because I'm a clinician leader, right? I still
Right.
do. As I said, I just worked in the ICU yesterday. I was
Yeah.
on call last night. It gives you street cred. For Steve Matchett, our CEO for
Yeah.
critical care, says when you work in the shift, you work in that ICU, as the leader, as the regional medical director, and I have, it gives you street cred, right? Because
Yeah.
I've
It
been
does.
there, I understand, and
It
I think
does.
when it's harder when you have so much responsibility for a system, but I think that's so important. That's something to remind all of the admin colleagues that are listening to this, and just a note, if you hear drums and piano in the background, that's my son practicing. So sorry about that. But
I don't hear a thing, and if I did, I'm sure it would be wonderful.
It's
But
actually good. He learned how to do the Mario theme. I'm really proud of him.
nice.
So yeah, to maintain that connection and maintain that, so that you really get street cred, so that you're not just the suit from you're the suit from, like, for me, I'm the suit from Chicago.
Yeah.
When I said, when they come and I say, well, okay, well, I work the shift. I know what you're talking about.
Yeah, no, it is the ultimate. I always say that, right? Bill Belichick, greatest football coach of all time, never played football, but medicine's different. Is medicine.
Totally.
You have to. My belief, right? It's certainly my bias, is that you had to have somebody say that you were an excellent clinician in order for you to advance in leadership. And so, I'm glad I've worked shifts. I'm glad I've worked at the bedside with a lot of folks, because, at least I can point to people and, like, well, they can tell you how I was as a doc, and hopefully you see that reflected in how I am as a physician executive. So, yeah.
Absolutely. I think, yeah, it's great to wear, one half the lab coat and the other half the suit. You
Exactly.
look quite dapper, by the way. You always have. And
Thanks.
think that,
I joke. I dressed like this in high school because
did you really? Did you really?
Yeah, I did.
Wow. That does, knowing you, that does not surprise me one bit, to be honest. And that's so important to stay connected. And I think, Unity Point is lucky to have you, because you remember, because a lot of people don't know, like, what do you,
Yeah.
I'm here, I'm working Sunday afternoon. And I said that yesterday. I'm like, I have zero sympathy. If you have to come in on Sunday, well, guess what?
Yeah.
I'm here on Sunday.
Yeah.
And if I'm here on Sunday, you're going to have to come here on Sunday. You know what
Well,
I'm saying?
and to that point, right, right, if you're not going to be at the bedside, then people need to know that you're working as hard as they are, because, and so it's nights, it's weekends, it's whatever it needs to be be in support of our teams that are taking care of patients, and I'm right there with you.
That's awesome. That's awesome. Well, Dr. Greg Johnson, I so appreciate your time. It's been great to connect and see you again. And we'll definitely keep in touch. I'll have you back, and we'll have further conversations. So appreciate you so much. And thanks for all you do.
Thanks, Hashem. Appreciate it. Appreciate the invitation, and we'll absolutely stay in touch. Take care.
Absolutely. Take care.
Thank you for watching. To get every episode delivered directly to your inbox, please subscribe at healthcaremusings.com.